afternoon, everybody. Before we begin, I'd like to acknowledge the land that we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, the Wendat peoples, and is now home to many diverse First Nations and Métis peoples. We also acknowledge that Toronto is covered by Territory 13 with the Mississaugas of the Credit. Welcome, everybody. My name is Michelle Wright. I'm the coordinator of Patient Support Initiatives at Lung Cancer Canada. I'd like to welcome each and every one of you here today, both in person and online, to our Toronto Lung Cancer Summit. I'd like to thank Dr. Amir Safavi for his help in bringing this event to fruition. I'd also like to thank each of the speakers here this afternoon for joining us and sharing valuable information and resources. Lung cancer is too often a forgotten cancer. We at Lung Cancer Canada work to support persons living with lung cancer, their care partners, and families with support services, education, and resources. Our mission is to educate, advocate, and support the lung cancer community. With that said, I'd like to welcome our first speaker, Dr. Brandon Sheffield. Dr. Sheffield is a diagnostic pathologist and the founder and divisional head of the Advanced Diagnostic Division at William Osler Health System. Dr. Sheffield also serves as the Director of Molecular External Quality Assurance for the CPQA, Canada's National Pathology Quality Organization, and the Regional Lead for Mississauga, Halton West, and Cancer Care Ontario. He's authored over 50 peer-reviewed publications and recently published his first textbook on molecular pathology. Dr. Sheffield's main clinical and research interests lie in the delivery of biomarkers to support precision cancer care in real-world scenarios. Welcome, Dr. Sheffield.
Right on. Thank you so much, Michelle, for the intro and for having me here. I have to say, I'm really sorry that I wasn't able to attend live. There's been a virus going around my house, and it just got me for the past couple of days. So thank you very much to the Lung Cancer Canada team that allowed for the pivot. And I'm sorry to everyone. I really wish that I could be there live and in person with you guys for this afternoon. Nonetheless, we'll still talk a little bit about lung cancer in the laboratory, and I'll try and give you guys an update about what's going on behind the scenes. So, as Michelle mentioned, my name is Brandon Sheffield. I am a pathologist. Most of you might not have met a pathologist, but there's definitely a pathologist involved in every cancer journey. We go to medical school just like an oncologist or a surgeon, and then following medical school, we do a 5-year residency. And after that, we spend the rest of our careers locked away in a hospital basement somewhere, looking at biopsies, surgical resection specimens or parts that have been removed, and helping to make sure that everybody's got the right diagnosis and the right treatment prescribed by their clinical team. So I want to show this picture, and I know that a lot of you in the audience are lung cancer advocates, and many of you know that these data may be better than myself. But I always like to look at this and remind myself that lung cancer is the #1 cause of cancer-related death for Canadians. And in this picture, we're looking at just Canadian women. Lung cancer kills more Canadian women than breast cancer, colon cancer, and pancreas cancer combined. And the Canadian Cancer Society every year comes out with a new publication that's really fantastic. It highlights some of this information in a way that we can present it to those people who need to be educated. And every year, Canadian Cancer Society comes with a new sort of colorful way of showing this that's pretty and nice to look at. But to be totally honest, I went back to this older one that's from around 2016 in this kind of gross color that I don't really like. But I thought that the way this story is shown is very cool because it shows not just what's going on right now, but our past. And if we go back 30 years and we look at what was happening in the early to mid 1980s at the left-hand side of this curve, you can see that at that time, breast cancer was actually the leading cause of death for Canadian women. And then when we fast forward to modern day, 30 years later, the mortality rate for breast cancer has dropped by 50% compared to what it was in the mid 1980s. And I think that drop, that 50% reduction in mortality, that is a very reasonable goal for what we hope to achieve in lung cancer in the short to medium term. And when we think about what happened to breast cancer over those 30 years, there's a lot that's changed, but things like screening come to mind. And we definitely have a screening program in the works for lung cancer. This has been recognized. Ontario is going to be adding a publicly funded screening program. But one other thing that comes to mind is the personalization of the care. And that in the mid 1980s, breast cancer was breast cancer. And throughout the 90s, we learned how to separate breast cancer into a series of individual diseases, whether the hormone receptors were positive or HER2 is driving that breast cancer or none of the above that we call a triple negative disease. And that personalization, to me, is one of the main factors that really drove down the mortality rate and drove up the efficacy of our treatments. So for the rest of this talk, I'm going to talk about how we can personalize lung cancer and what new tools we've got available. So I'm big on understanding where we came from, and this is a really cool picture I like. It's called the anatomy lesson of Nicholas Tulp, and Dr. Tulp is the one in the cool hat on the right, and this is really how pathologists learned back in the day. And for over 1,000 years, the art of pathology was practiced by looking at body parts, by touching them, by feeling them, by smelling them, even drawing them sometimes. And really, to be totally honest, we did not learn that much about diseases like lung cancer. Our understanding of cancer really exploded in the late 1800s when a very key invention came out, and that was the microscope. Here you can see this is Dr. Masson. He was a pathologist at McGill and believed to be one of the founding fathers of Canadian pathology. And the device by his right arm there is one of the earlier microscopes. You can actually see that if you can see me on your screen, I'm not sure, but I've got a similar one right beside me right now. And that really changed everything because for the first time in the history of medicine, doctors could see cells and they could tell what if a cell was benign versus if it was cancer. They could even figure out ways in which breast cancer looked different from lung cancer, looked different from colon cancer. And for the first time ever, we could tell surgeons what body parts needed to be removed and which ones didn't. And when they did remove them, we could say whether all the cancer was removed or whether there was some left behind. And this really gave rise to the idea of surgery as a powerful means of cancer control. And for nearly 200 years, surgery has remained the mainstay of cancer treatment. And the principles that were first described in the late 1800s around tumor cell recognition are still used today. So basically this is it in a nutshell. On the right, we have a nice looking cell with a appropriately sized nucleus where they keep all the DNA. And then on the other side of the screen, we have a funky looking cell that's all weird and misshapen, and that represents cancer. So over 100 years later, this is me during my residency training. And the microscope that we're using is really not any different than the one that Dr. Masson had on his desk. And the art of recognizing tumor cell hasn't changed at all. You can see on my computer screen there, we're looking at the same blue and pink images. And then this picture was taken 10 years after that. This is me at my hospital office. And again, with the exact same microscope, you can see the screens on the left now, looking at more blue and pink cells. And embarrassingly, I'll show you, I think I'm wearing the same shirt in both photos. So you know, some things just never really change. But excited to be here to talk to you guys today, because I think that for the first time since the late 1800s, we're actually experiencing another explosion in the way we understand cancer as a disease. And that has to do with DNA sequencing. So DNA, this kind of picture that you're seeing, the structure of DNA was first elucidated in the 1950s. Gene sequencers were first, the sequencing technology was invented around the late 60s and 70s. The first human genome was sequenced just after the year 2000. And it took $1 billion and 10 years to sequence the first human genome. But the technology has improved so much that today it takes about 1 day and costs $1,000 to sequence the genome. And the technology is very similar, if you can imagine a cell phone that's sitting in your pocket right now, or maybe in your hand if you're texting. This is a modern day gene sequencer, and here our technologist Andrea is loading that up with cancer samples. This can exist in a community hospital, and when we put DNA onto this machine, the very next day we can get sequence results out and help tell oncologists what type, individual type of lung cancer they might be dealing with in their patients. And remember, that first human genome in the year 2000, just over 20 years ago, cost $1 billion and took 10 years. Machines like this are doing the same thing in about 1 day for less than $1,000. And that's really changed everything for us and for you. The personalization only goes so far. What we need is discoveries on the other side of the wall, specifically the drug makers who are coming out with new targeted therapies. And every time we find a new targeted therapy that works on a specific type of lung cancer or breast cancer or stomach cancer, we tend to need to identify a specific gene mutation that's made that cancer malignant in the first place so that we can match to the new targeted therapy. On this chart, NSCLC is fancy doctor speak for lung cancer, but you can see it's right at the top of the list. Ahead of that's hormone receptor positive breast cancer, TNBC is triple negative breast cancer, CRC is colon cancer. And lung cancer is really led by having more than a dozen new drugs that have been brought to market each year, and that number continues to grow. And I think we're going to have a talk later on today about what we can do to make sure these are available to us in Canada. But after we get them approved by Health Canada and funded by our government, then the next thing we need is a gene test to go along with that drug so we can make sure we're prescribing it to the right person at the right time. Now, why do we want these targeted therapies? For starters, they work a lot better. And it doesn't matter which therapy we're talking about. When a therapy is custom designed for you, it tends to be more effective than when a therapy is generic and designed for a whole population. Not only does it work better at treating your cancer, but the side effects are considerably less than when we use non-targeted or more generic therapy. So all of this is based on traditional gene sequencing. And in traditional gene sequencing, we take a piece of cancer, either one that was removed by a surgeon, if you had a whole lung removed, or a small piece of a tumor that comes from a biopsy procedure. And in this picture, you can see this is a radiologist. Radiologists are very nice, personable, good-looking people that you might meet along your journey, not at all like pathologists who are trapped in the basement of that hospital. They don't like when we talk to patients or even be seen out in public. Here you can see the radiologist is putting a needle through this patient's chest to get that tiny little piece of tumor so they can send it to the lab. And, while we say it's no big deal, it's very safe, The radiologists train for many, many years to be able to do this like total pros. It's still unpleasant. None of us want to go through this procedure, and there are risks to it. So to that end, one of the biggest developments we've seen is on how do we do this without taking that tiny little piece of tissue. And just to make things harder on lung cancer patients, these biopsies tend to be very, very small. So you can see compared to the size of a paper clip, that's what a typical lung cancer sample looks like when it's in the lab. And then by comparison, this is what we're working with a typical breast cancer sample. And that makes sense when you think about where breasts are compared to vital organs like your heart and aorta. It's easier to get a big sample like that safely, and we're not at risk of damaging anything important. So liquid biopsy is a term that's often talked about right now, and that's how do we get this genetic information without taking that tissue sample? And if you'll permit me a sec, we can all become scientists for a moment, and we'll talk about how a liquid biopsy actually works. So at the top of this picture, they're showing a bunch of blue and kind of turquoise cells. And based on the picture we've seen, those are benign cells. They're nice and round, and they're clearly shapen. And these might represent cells in a body part, like a liver or a leg muscle. And all of our body parts, all of our cells are connected to the bloodstream. That's how they get their oxygen. It's how they get their sugar, their food. And all cells in all of our body parts die sometimes. And when they die, they release a little bit of their DNA into the bloodstream. It happens regularly. Like if I was to bump my leg on a table or get a bad cramp or even just regular existence sitting in my chair at my desk, cells die from time to time. And we can find that DNA in the blood. At the bottom of this picture, there's these kind of funky looking green cells that, because they're weird looking, they're meant to represent a tumor. And tumors will connect to our blood supply the same way our regular body parts do. And tumors will co-opt those blood vessels because they want to take oxygen and sugar and other nutrients so that the cancer can survive just the same way a body part would. Cancer cells also die regularly, not just from therapies like chemotherapy or radiation, but they just die naturally, normally on their own. And when they do, they release cancer DNA, which is a little bit different than our normal DNA, into the bloodstream as well. So if we were to take a tube of blood and use our gene sequencer to look at what kind of DNA is floating around in that blood, we'll often find little bits and pieces of cancer DNA. And using that principle, we can profile and analyze cancer DNA without ever taking a tissue biopsy and putting patients at risk of that painful procedure. So that's liquid biopsy in a nutshell. If you don't understand fully, I think that's okay. Most doctors still don't fully understand this, and that's so they keep people like me around to run these things. This technique is being used regularly in a different medical condition called pregnancy. So we use different words when we talk about pregnant ladies. Everything just is a lot more pleasant when we're dealing with the prenatal ward or the labor and delivery ward. So, but fetuses and babies have genetic issues just the exact same way that cancer patients do. And it was frequent for many years, if not decades, to screen pregnant mothers for genetic diseases, things like trisomy 21 or Tay-Sachs disease. And if we thought a baby was at high risk for having one of these, we would biopsy a fetus. They don't call it biopsy a fetus because that sounds unpleasant. They use terms like chorionic villus sampling, but essentially it's putting a needle through the skin to get a small piece of tissue so we can analyze it in the lab, which is a biopsy. That was later replaced in the past 5 years or so with what we call non-invasive prenatal testing, or NIPT, which is a very fancy and nice word for liquid biopsy. And now it's standard for all pregnant women to have a liquid biopsy of their fetus at around 10 to 12 weeks to check for genetic abnormalities. And this is being nicely funded and delivered to our obstetrical patients right now. And it's really changed the way we look at prenatal care for pregnant women. Now, when we going back to the cancer space, liquid biopsy is incredibly useful at detecting mutations. So figuring out which type of lung cancer you have, whether it's EGFR or KRAS or ALK. It's really good at finding resistance mutations. Say we're on an EGFR inhibitor and it stops working. A liquid biopsy can help figure out what the next most appropriate treatment would be after we determine why the current treatment stopped working. But then there's a whole bunch of other uses that have yet to be formally adopted. Things like monitoring patients, seeing if that cancer's come back in a quicker way than things like CT scans might diagnose a recurrence. Even establishing a diagnosis during that period when patients first become symptomatic, this can be a valuable tool if it's not easy to perform a tissue biopsy. There are types of liquid biopsy as well that can be used for screening and early detection, and then some that can be used to help tell doctors which patients were cured after surgery versus which patients need a little bit more treatment. And there's also continuing looks at how we might use this information to stage our patients or to better predict how they're going to do with different lung cancer treatments. So everything's hard for us in Canada, where we always have something to fight for. We get to live in the greatest country in the world with a lot of benefits, but we do have to fight for our health care. So, and this is a team effort. It's something that your physicians are definitely doing every day, but it's something that we always do appreciate the help of our patients when it's time to advocate for this. And remember that lung cancer is the #1 most common cause of cancer-related death. So lung cancer patients have a loud voice, and when we say something, it is listened to. So for gene sequencing on a tissue biopsy, the traditional method, this is funded for us in Ontario, but it's still inaccessible for some patients because it takes too long. So in some hospitals, it can be done in under 2 weeks, which is a recommendation, but that's rare. In a lot of hospital systems, patients are having to wait more than 2 months, which we think is unacceptable. So even though this is funded, there are still Ontario lung cancer patients that cannot access this basic standard test. For liquid biopsy, there is no public funding to get this. You can get a liquid biopsy on your own through the private system. There are no private labs in Canada offering this right now, but there are US-based private labs. And it's actually fairly easy to arrange your own liquid biopsy. If you were to go to the website of a provider like Foundation Medicine or Guardant Health, the website will actually direct you to how to get a blood draw, and you can arrange this at a local lab, local blood collection facility that's close to your house. It's very easy to do. It can cost somewhere between $2,000 and $6,000. So I don't recommend that anybody goes and does this on their own, but if you're willing to pay extra or have insurance that might cover it, I do recommend that you just let your oncologist know that and just say, hey, by the way, if I ever need this or if it ever might help with my care, I'd be willing to do that. And I think just putting that information out there can be very helpful, because sometimes oncologists and other doctors are hesitant to recommend something that costs extra money beyond what our public system is covering. That being said, we are currently advocating as best as we can to get this covered through Cancer Care Ontario and through the provincial government, but we're still probably a few years away from seeing that happen. Now, in terms of advocacy, there are lots of groups, including Lung Cancer Canada, working very hard to address these. Here you can see this is a recent paper by lead author, our president of Lung Cancer Canada, Stephanie Snow, looking at barriers and unequal access to molecular testing in Canada. And just recently, this was out just this week, another group of lung cancer treaters from Ontario showing that they're having a really hard time getting access to timely molecular tests. And they showed some of the results this has been having on the patient care that they're able to provide. So ongoing effort there, and if anybody is up for some more advocacy, there is a lot of work to be done. I'll share with you just before we close one effort that we believe is going to really help this, and this is being done through an organization called the Canadian Pathology Quality Assurance, and we're set up to be somewhat of a watchdog and to make sure that we monitor labs' performance and how they do with biomarker testing. So very quickly, we designed fake cancer samples on the top left of that screen. They're meant to mimic what real life cancer samples would look like, and we send them around to laboratories across Canada. We measure how long it takes them to perform their analysis. We give the reports to a team of experts and ask them to prescribe treatments. And then we look and make sure that no patients with a certain cancer would get the exact same treatment regardless of which hospital they presented to for their diagnosis and for their treatment. Unfortunately, we're not quite there yet. We do see treatment differences across Canada depending on where patients are diagnosed. But we believe that this is going to be one of the key efforts that'll help standardize and erase that inequality around cancer treatment in Canada. So many thanks for your attention and for coming today. I'm sorry again that I couldn't be there in person to hang out with you guys. But if there's any questions, I'm happy to answer them now. Or if anybody wants to ask privately, I'm happy to take your questions by email as well too. So thank you again.
Thank you, Dr. Sheffield. Does anyone have a question?
That was a really informative presentation, and I loved your graphics and your ability to communicate it to non-scientific lay people in a way that we can understand. My question is, what percentage of Canadians are not receiving biomarker testing before they're given some type of treatment? I'm assuming it's usually chemotherapy.
That's a really good question. So I don't know the answer. Nobody is measuring that across Canada. We do measure in our own hospital, and we know that in our hospital, our goal is that 100% of patients have their biomarkers, not just before treatment, but before they meet with their oncologist. In the last report that I showed from this group of lung cancer treaters, they said that 80% of lung cancer patients were showing up to their consults without biomarkers. So almost a total opposite from two hospitals fairly close together. While I don't know the exact number of patients who don't have biomarkers when they start their treatment, what I can tell you is that research has shown starting treatment without biomarkers is a really bad idea. And if patients are to start treatment without their biomarkers and the biomarkers become available later, the negative effect of having started the wrong treatment never goes away. So in terms of what we need to improve on as Canadians in our lung cancer treatment, I would say that having timely access to biomarkers is front of mind for me.
Absolutely shocking. And I'm a patient, and I've got tears in my eyes just hearing you say this. And I think this is a really good goal and opportunity for all of us who are lung cancer advocates to speak into that, because that's not what I do. Glad to help. And I can
Thanks for the question.
Yes, absolutely. I do know that varies greatly from province to province. Anyone else have questions or comments?
This is through the online chat. I was interested to learn that cancer cells die. The widespread public perception is they are immortal. Is this a new understanding?
So the tumors themselves can be immortal. And when we look at them under the microscope, we see that cancer cells are actually dying all the time, but there's new ones being born. And they tend to have, like when we look at a normal tissue, we don't see any mitoses, which is how mitosis is when a cell divides into two new ones, and is how a new cell is born. So if you were to look at your skin or colon or normal lung, the cells aren't doing anything. They're neither dying nor are they being born. When we look at a tumor under the microscope, we see lots and lots of mitotic activity, but lots and lots of necrosis as well. The reason why a cancer or the tumor grows and spreads is because there's unfortunately more mitotic activity than there is necrosis. And so the net effect is that the tumor itself is growing and the tumor is immortal, but the individual cells will die. And a lot of the cancer treatments that we give are meant to convince the cancer cells that it's time for them to die.
Thank you. And just another question online. Targeted therapy has reduced my stage 4 EGFR tumors to around 2 centimeters each. I'm trying to decide whether to add radiation or consolidation. Is there a role for ctDNA to help inform the decision to add radiation or consolidation or not? Is there a limit of detection for my small tumors around 2 centimeters, for which ctDNA would not detect?
That is an incredible question. Like, what you're asking about is remember I showed this triangle where at the top we had sort of some established uses of liquid biopsy, like finding your EGFR mutation or finding that resistance mutation should one arise. But what you're asking about are some of the uses of liquid biopsy that are emerging. Minimal residual disease detection after you start on that tyrosine kinase inhibitor, that EGFR inhibitor, and wondering if there's any circulating tumor cells that are detectable, if that would help you decide on whether or not to go for the consolidative radiotherapy. That's an incredible question to ask, and it's issues like this that we actually discuss every single day as a multidisciplinary tumor board. So I typically get questions like that from radiation oncologists, from medical oncologists. This is the first time I've ever had that question from a patient, and it's amazing that you're asking that. I think that the decision to go ahead with radiation, in not just your case, but in all of them, has to be a joint decision between yourself, the medical team, as well as anybody else who's involved in your care. The fact that you're in the driver's seat like that and making the decision on whether or not to go for the radiotherapy, I think is amazing. I don't know if liquid biopsy would help you, but I'd love to try. And if you're willing to try and you're willing to pursue it, I would recommend mentioning that to your medical oncologist and to your radiation oncologist, and hopefully they can help you arrange it. The thing is, if it's not helpful, it won't hurt you, but it can cost a bit of money. And so we are cognizant about financial toxicity, and depending on where you come from, what you can afford, I think it's reasonable to try.
Thank you, Dr. Sheffield. Time for one more.
Thank you, Dr. Sheffield. In your experience, what does it take for the government to we know they have limited resources. What does it take for them to reach a point where they say, we're going to start to fund this?
So that's one of the issues and the difficulties that we face in Ontario is that there's no straight pathway to answer that question. And so how we got our funding for tissue NGS, it seemed to be that there was a story that reached one of the members of provincial parliament. It was one of your guys' stories. And after that, a decision was made to fund tissue NGS. There's no form to fill out or number to call or anywhere where we can really start that discussion. It turns out that the Ministry of Health is dependent on special interest groups like Lung Cancer Canada to start making noise about inequity. And following that, we might see some action. Typically, we'd see an economic assessment carried out by one of the branches of the Ministry of Health. And then that economic assessment will be put forth to a separate committee to review. And if it's viewed as a positive, then funding for it will be issued from the provincial government through the Ministry of Health, through Cancer Care Ontario, to a select number of labs that could perform the test. I imagine it can go fairly quickly when we put pressure on the system. But again, I think we're still in the very early stages, if that, for looking at liquid biopsy. And so access to this for anybody who's sick with lung cancer right now is going to have to be through these creative means or private pay. And the work and advocacy we do in liquid biopsy will mostly benefit the people who are diagnosed with lung cancer tomorrow.
Thank you. Goes to show that patient stories are powerful, and they can move the government mountains. So sharing them with us and sharing them with others can have a real impact on others.
I think it's a lot to ask of you guys, and we feel, but the honest truth is that when you share your story, you are listened to, and our payers, our government is a lot more likely to listen to you guys than to the physicians. So if you're up for it and you feel that you have it in you to tell that story, please do. I think it's incredibly helpful for everybody suffering from this disease.
Thank you.
Thanks, everybody.
I would like to introduce Dr. Breffni, Hannon. Hopefully I'm pronouncing that correctly. Dr. Hannon leads the Palliative Care Program at the Princess Margaret Cancer Center at the University Health Network in Toronto, and is an associate professor in the Department of Palliative Medicine at the University of Toronto. She's a graduate of University College Cork in Ireland, came to Toronto for a 2-year fellowship in 2011 and never left. Her research interests include early palliative care for patients with advanced cancer, understanding the experiences of caregivers of patients with advanced cancer, and patient-reported outcome measures. Welcome.
Thank you. Can everybody hear me okay? Speak closer to the mic. Okay, can everybody hear me? Great. It's lovely to be here. Take this one. Okay. I'll try not to blow everybody's heads off with my with my loud voice. It's lovely to be here. Thank you so much to Amir and Michelle for the invitation to speak on St. Patrick's Week. So I feel very at home with the green background here. Thank you. Yes. And really excited to have an opportunity to speak about palliative care at this incredible event. I think I'm always looking for opportunities to demystify and destigmatize some of the ideas that folks might have around palliative care. And such an honor to speak with such incredible speakers, including Bev and Amir and Dr. Sheffield, who we've had today. So thank you so much again for the opportunity. So what I briefly want to do is kind of socialize the idea of the term early or timely palliative care, to describe how palliative care might fit into your treatment plan as somebody who's experiencing lung cancer, and maybe make some suggestions about when and how an introduction to the palliative care team may be helpful for you and your family. So a little bit of Latin to start off with. Who doesn't like a little bit of a linguistics class on a Thursday afternoon? You know, the word palliative has so many negative connotations that I sometimes think that it's really helpful to strip that back and talk about where the word came from in the first place. And as you can see, it means nothing to do with death or dying or the end of life. It actually comes from the Latin word pallium, which means to cloak or to cover. And I like to think of it as meaning our job as palliative care doctors and palliative care teams isn't to cure the cancer. That's the job of Dr. Sheffield and Amir. Our job is to cover up or to manage the symptoms of the illness without curing it. And so hopefully that helps you understand why we persevere with the name, despite some people's feelings that we should change it. And in fact, when you look at the World Health Organization definition of palliative care, you will also maybe be surprised to see that there is no discussion about the end of life or death or dying in that definition either. And it really focuses on the idea that palliative care is an approach to improve patients' and their families' quality of life. But for folks who are facing the problems associated with a life-threatening illness, our job is to prevent and relieve their suffering. And we do that ideally by means of early identification, by using impeccable assessment tools, and by treating their pain and their other problems, be those physical, psychological, or spiritual. And I've highlighted the early identification there, and this is a theme you're going to hear me talk about a lot over the next little while. And so, you know, historically, palliative care was very much rooted at the end of somebody's life. And I think when I talk to patients and families about palliative care, there's still this overwhelming perception that our role is only valuable at the very end of somebody's life, when maybe they're no longer having treatment, they're no longer able to come to their treatment centre, and maybe they're spending more time at home, in their bed, not able to do so much for themselves. But how we practice palliative care has changed a lot over the past 10 to 15 years, really in tandem with a lot of the changes my colleagues have talked about today about advances in cancer treatment. So there's been a steady shift towards involving palliative care specialists much earlier in the patient's disease journey. You heard from the oncology and the radiation colleagues who've spoken here today how the explosion, to use the word of Dr. Sheff, is the explosion of options and treatments that have come in terms of cancer treatment and diagnostics. And it's impossible to expect that any one clinician can do all of those things, can keep up to date with all of the different treatments, all of the different diagnostics, the genomics, the biomarkers, SBRT versus radiation. No one person can do this, and this is very much a team sport. And this is where our team comes into play in a very positive way. And I'm going to describe some studies to you over the next few slides that really demonstrate that quite clearly, the benefits of early palliative care, including one that we did at Princess Margaret. But over and over, what we're emphasizing is that our role in somebody's care is to help manage their symptoms. So basically to help our patients and their families feel as well as they can for as long as they can, so that smart people like Amir and Dr. Sheffield can continue to come up with the incredible treatments that keep our patients living longer and living better. And so the graphic on the top is kind of the old-fashioned model of palliative care, where somebody would be diagnosed with cancer, they would, go through their treatment, and a time would come when treatment was no longer possible or there were no further treatment options for them. And at that point, their care would be very much handed over to a different team, a palliative care team, who would look after them until the end of their life. And that was often quite a short portion of somebody's life. Now what we see is more of this shared care model, like what you see at the bottom. So we often get involved in the care of patients from the time of diagnosis of advanced cancer. And as you can see, our involvement, which is the darker blue shading, changes over time. So maybe in the beginning, we're helping to manage some symptoms and we're peripherally involved as the oncologists and the radiation teams are managing the day-to-day care. But over time, perhaps there are more symptoms, there's a need for some more home supports, some emotional supports for patients and their family, and our involvement tends to ramp up over time in tandem with perhaps oncology treatments ramping down depending on how somebody's care is evolving. But the whole point being that we're there from the beginning, and we're building relationships and rapport with patients and our families that are enduring and help us really support them in making the right decisions for them and their families when the time comes. And so to talk about the research behind this, which is actually quite relevant when it comes to lung cancer, From about 2009 onwards, we began to see a lot of very high quality research coming out, demonstrating the benefits of early palliative care. So you don't have to just take my word from it. There's a lot of very good and strong evidence to support this. And in particular, I want to talk about one study, and the one that I've highlighted here on the bottom, which is called Early Palliative Care for Patients with Metastatic Non-Small Cell Lung Cancer. So from my earlier colleagues, you now know what non-small cell lung cancer looks like under the microscope, and you've heard about journals like the New England Journal of Medicine, which is one of the highest ranked medical journals in the world. So this is a very impactful paper. And this really was a game changer when it came to how palliative care is integrated into the care of patients with advanced lung cancer. So this was a study in the US where they took 151 patients with newly diagnosed stage 4 non-small cell lung cancer. And they broke them into 2 groups. The first group saw their oncologist just as usual, and they continued along their care. The second group saw their oncologist, but they also saw a palliative care team. And some of the results were really surprising. So they had 3 outcomes of interest. The first one was they wanted to see the impact on patients' quality of life. So that's what you see on the chart on the left-hand side. So higher is better for this one. So the patients who just saw their oncologist, they had an okay quality of life, but it didn't change. You can see on the y-axis that it's the circle is right there by 0. So there was really no change from the beginning of the study to the end of the study in terms of patients' quality of life. For those who saw the palliative care team, it was significantly better. So it was close to 5 points better on this scale when they saw their oncologist and the palliative care team. You might say, okay, quality of life, I don't really know what that means. Give me some better evidence. So let's move to the graph on the right. We also looked at mood, so depression and anxiety. The blue chart is the patients who just saw their oncologist. The red is the patients who saw palliative care. And in this instance, lower is better. So you can see that patients with depression, that's the first one on the left, dropped quite considerably between the 2 groups. So the patients who received early palliative care were significantly less likely to suffer from depression. They were less likely to suffer from anxiety. And the graph on the far right is another depression scale called the PHQ-9. And again, you can see there's a big difference between the blue and the red there. But the really important finding, which deserves a slide all of its own, was this one. So this is what we call a Kaplan-Meier survival curve. So this shows us how long people lived. So the blue here are those patients who just saw their oncologist. So looking at the left, the top left where it says 100, you're moving downwards. And each of those little data points is a patient. So you can see at the start, everybody was alive. And over time, you can see there's a big drop down on the blue side. So those are all patients who just saw their oncologist, did not see a palliative care doctor. And their average life length of their survival was about 8 months. The red, however, you can see that there's a big gap between the blue and the red. And what was really noteworthy here was that the patients who saw the palliative care team, as well as the oncology team, lived for longer. So they lived for up to 3 months longer, which when your average life expectancy is only 9 months, that's pretty significant in anybody's life. Now, Beth has already told us that the survival advantage for patients with stage 4 lung cancer is now completely different than it was in 2009. But this is a really meaningful difference. This is both statistically significant, which is what our scientists get really excited about and why it gets published in a journal like the New England, but it also makes a difference to patients' lives when you think about it. When the authors of this study tried to explain that, lots of people said, oh, maybe the patients were different, or there was something different about the patients in one group versus the other. There was not. There was the same number of men versus women, the same subtypes of cancer, the same racial and ethnic groups. There was really no difference that anybody can come up with then or now, apart from the fact that they saw the palliative care team, which really demystifies a lot of the stigma that patients think when I see a palliative care team, maybe that means I'm going to die sooner rather than later. And here we are having a really high profile study showing us that quite the opposite is true. And this has had such a monumental seismic change in how the thoracic oncologists refer patients to palliative care. Where I work at Princess Margaret, almost every patient at the time of diagnosis of stage 4 lung cancer, and America attests to this, gets referred to the palliative care team. And it doesn't matter if they have symptoms, or what is going on with them. But there is a recognition and an acknowledgement that we have a skill set that helps people to live better, live longer, and be better, equipped to deal with further treatment options, get enrolled in clinical trials, and to support them right up until the end of life. So around the same time, our program at Princess Margaret was also doing a randomized controlled trial of early palliative care. And while we didn't measure survival because we were looking at patients with a variety of different types of cancer, what we did was, to add to this literature, was we did a lot of interviews with patients and caregivers who had experienced early palliative care. Because after we showed all of those results that I showed you earlier on, the next question is, well, what is it? What is the secret sauce? What is it that palliative care is doing that is helping these patients live longer and live better? And so we asked them. So we said to patients, okay, what was it like? What was it like coming to the palliative care clinic? What was it that we did that was different to what you experienced in oncology? And they highlighted 4 different things. They said coming to the palliative care clinic meant they had prompt, personalized symptom management. So it wasn't just this is the pain pill that we prescribe for every patient who comes to the clinic because we're really busy and we don't have time to figure out what to give you. But we would spend time with each patient trying to figure out exactly what was the right treatment for them at the right time. We provided more holistic support. So it wasn't just about the patient, but it was also about the patient, their family, their loved ones, the circle of people that surrounds them. They felt that the palliative care clinic was also a really safe space to kind of make decision-making about the future. So they would sometimes bounce ideas off us because, of course, their oncologist will sometimes say to them, well, you can have treatment A or you can have treatment B. Like we heard already today. You decide. You tell us what you want. And sometimes that's hard. That's hard as a patient to figure out what is the right thing to do. So sometimes they would come to us and they would say, can you help me understand this a little bit more? Can we talk through this? Can you go through my CT scan report? Can you spend a little time just helping me answer some additional questions that perhaps I didn't have time to talk about in my oncology appointment or have come to me since? And it also helps people feel better prepared for the future because, no matter what happens, I think for most patients when they get a diagnosis of advanced cancer, your mind goes to dark places and you do start to think about the future. And you do start to think about what might happen for you and for your family. And so our team, because of our skill set in supporting patients up until the end of life, are very equipped and able to have those hard conversations about your goals, your values, your wishes, and your preferences when you do come to the end of life. And I guess it's that old story of you don't know what you don't know, right? So if we take a bunch of people and we put blindfolds on them and we put them at a different part of an elephant, they're not sure what they're feeling. It's a spear, it's a fan, it's a wall, it's a rope, it's a tree, it's a snake. What we want to do is see the bigger picture and allow patients to understand that palliative care is just not one thing, but it is many things. The other thing that we wanted to do was kind of understand whether patients' perceptions of palliative care changed on the back of coming to the clinic early. And it'll come as no surprise here that when we interviewed patients who had received this intervention and we asked them, what was your perception of palliative care? What did you think of palliative care at the beginning? I mean, they all said, yeah, death and dying, the end of the road. It's a time when I'm going to lose my independence, when there is no more hope for me. In fact, those patients who saw us early said they had a really different opinion, that it really had changed their perception of palliative care and that they could see how it had much more of an impact on their overall well-being and that it was not necessarily what they had originally thought. And we also asked them, well, cancer oncologists do this? Because that's another question that gets asked all the time. These amazing oncologists, they're so talented, they know all of these treatments. Why can't an oncologist do what you do? What is it that's special about you? So we asked for patients, again, because patients are the best people to answer these questions. And what we heard loud and clear was, no. My oncologist has a very specific role. And their role is to focus on my cancer and my cancer treatment. That's their job. And that's what I want them to do as a patient. I want them to be able to focus on the latest results, on the latest, studies that are coming out to figure out what is the right treatment for me right now. Palliative care team, however, I want them to be the ones to manage my symptoms and to do that in a really precise and focused way. I understand that my oncology visit is going to be more structured. It's going to follow kind of a formula. I'm going to go in, I'm going to have my blood work and my x-ray. Maybe we're going to talk about my CT scan. We're going to see how I got on with my last cycle of treatment. But you know better than I that sometimes that's a very tight appointment. It might be 10 or 15 minutes with your oncologist. So there's a lot of things to go through. And your doctor has a lot of questions that they have to ask before you get to ask yours. Whereas in the palliative care clinic, patients told us they felt that they were able to lead those appointments a little bit better. So they had longer appointments, the visits were less structured, they were a bit more fluid, and patients were really able to set the agenda in a way that they felt was really helpful and that really complemented what happened in their oncology clinic. And the overall sort of message was that patients felt they needed both to have truly holistic, comprehensive care required not just a fantastic oncologist, but an oncologist and a radiation oncologist and a palliative care team who had discrete but complementary roles, and all were playing a very pivotal and essential role in their care. And on the back of all of this research, in 2017, the American Society of Clinical Oncology, or ASCO, published a recommendation that patients with advanced cancer should receive dedicated palliative care services early in their disease course at the same time as their active treatment. But yet the stigma persists. And so there's still a lot of folks who really feel very frightened and very nervous and do not feel that palliative care is the right thing for them. And just a couple of years ago, my colleague Camilla Zimmerman and Jean Matthews published this really interesting cartoon talking about palliative care being the umbrella, which I think is a really interesting metaphor. So, I mean, hands up, who in the room has an umbrella in their bag? Yeah. So you have an umbrella in your bag all of the time, right? You don't know whether it's going to rain or not, but you have an umbrella there and you feel very smart when it does rain and you get to pick out your umbrella. I have an umbrella because I'm from Ireland, where it rains all of the time, so it would be foolish to not have an umbrella, but however. So Camilla's idea was that palliative care is like an umbrella. So the top graphic is where, for the rest of you who said you do not have an umbrella, that's where you guys fit, right? So you don't have your umbrella, you're at your clinic appointment, you walk out the door and it's teeming with rain, and you get soaked going to the car, and somebody runs after you and says, here's an umbrella, but it's a little bit late, you're already soaked through and you're feeling pretty miserable. And you think, gosh, I wish I'd brought my umbrella with me, I wish I'd had this umbrella sooner. Early palliative care is the umbrella in this metaphor. So, at your first visit, you get the umbrella and somebody says, put that in your bag, keep it there. You're going to need it at some point. I don't know when it's going to be helpful for you, but it's a good thing for you to have. So when the rain does come, as it inevitably does, you're prepared, you feel like you're empowered and you have your umbrella and you don't get soaked. So the next question is, when is the right time to meet a palliative care team? And again, there's a lot of debate and discussion around this. And various different criteria have been described. Some people say it should be based on your disease stage or your estimated prognosis. Some people say it should be based on whether you have symptoms or not that are bothering you at that time. And some people say, well, patients themselves should be empowered to request it. But it's not that easy, because just like everything else, there were not enough palliative care physicians across Canada to provide care to every single one of these patients. And so we have to come up with other criteria. And it is also based on oncologists' comfort and experience. Some oncologists feel very empowered to refer a lot of their patients to palliative care. Some oncologists feel very empowered themselves to deliver what we call primary palliative care, where they can do a certain amount of that on their own and they feel very comfortable. And then they refer when things get a bit more complex. And some, unfortunately, but thankfully a number, are still in that old school model where they still equate palliative care to the end of somebody's life. And so those referrals are still coming late. So that is why it's really important to have an opportunity like this to come and to speak and to beat the drum for early palliative care. But if in doubt, what I always say is, you guys, as we've already heard in many of the talks today, the patient voice is the strongest one in the room. So if you think palliative care might be right for you, ask your oncologist, ask a nurse, ask somebody in the clinic if a referral to palliative care might be right and how that can happen for you. And certainly, we have incredible palliative care teams across the city of Toronto, and beyond, so it should be available no matter where you are. Thank you so much.
Thank you so much. Does anyone have any questions? No, any online, Winky? Oh, sorry.
Just thank you, Dr. Hannon. Is meditation, mindfulness meditation, is that part of what you do, and does that have some value?
Absolutely. So, we're so fortunate, Margaret, we work at wonderful resources that includes psychologists, therapists. There's the emotional side of things, as we know, is often overlooked, but it's so important. But I firmly believe that we can do ourselves, our the business for better, is really important. And mindfulness, whatever it is, that helps us to ground, stronger and better able to cope with things. So, thank you.
Thank you, Dr. Hannon, again. I know that there's that Palliative therapy resource for decision making, which is something that I've never had thought of, so I will recommend it for patients. Next, I'd like to introduce Dr. Ju-Yoon. Dr. Yoon pursued his training at the University of Manitoba, followed by an anatomic pathology residency at the University of Toronto, and clinical fellowships in molecular genetic pathology at the University of Pennsylvania, and gynecological pathology at Brigham and Women's Hospital. He served as a surgical molecular pathologist at St. Michael's Hospital, and his research interests are in early carcinogenic events for gynecologic and lung cancers, as well as molecular genetic techniques. He is the co-recipient of the Lung Cancer Canada Jeffrey Bogger Memorial Research Fund, and he's here to report on his research. Thank you.
Thank you very much. Thank you for having me here, and many thanks to the Lung Cancer Canada for the generous support for this project. My partner in crime, Dr. Kelsey Fu, could not be here today, but they were presenting on the behalf of Sarah as well. She is a busy scientist who her background is their ultimate goal of discovering a new and improved treatments for lung cancer to ultimately to improve patient care and outcomes, which is a very laudable goal, and very much interested in, among many things, immune aspects of the lung cancer. And when scientists think of cancer, this is usually how they present cancers. And so we talk about hallmarks of cancer and really about cancer biology with respect to things like use my notes. Not very well. Things like I keep up. Invading growth suppressors, which allows tumors to grow in the first place, but also in doing it in a manner that's invasive and going on to ultimately metastasize and go to other body parts. But that begets a number of different things, including immune responses. Very interesting in the lung cancer for not just biology and just for the sake of studying it, but now with the advance of various targeted therapies that target PD-L1, for example, that actually utilizes your own immune system to target the cancer in a meaningful way. Now we're going to take a step back, and one of the things that I'm very interested in as a pathologist is how did the cancer get there in the first place? We know about what causes lung cancer in many patients, unfortunately, and as a molecular pathologist, I spent a lot of time looking at computer screens. And actually, that's what I was doing last night. That's why I'm so tired, is because I was looking at the results from DNA sequencing results of numerous patients and signing out the reports that's discussed with your oncologist. So that's the DNA sequencing part. My other part as a surgical pathologist, and usually I'm the token pathologist in the room, but I was surprised I was preceded by another pathologist, is looking at the microscope. What I don't do is forensic pathology, which is the shows like that is, or in arguments with oncologist colleagues like Dr. House, or actually do my own pipetting. So that's where my technologists come in. Usually, by the time I get to any cases, it's been processed for me, and I'm either looking at process slides or results from various assays. And so, however it gets there, it's certainly a very, you're not meant to read in the text here, but just to say that when it comes to lung cancer, for pathologists like myself, it's a very rather complicated picture with a lot of different diagnoses. And even if I just focus on non-small cell lung cancer, however it got there, we have different phases of even just one small type, adenocarcinoma, that includes lipidic. So that's the earliest, one of the earliest forms of lung cancer that we recognize in situ form, and that is looking different from what you see there as acinar papillary micropapillary solid, which you recognize as invasive carcinoma. And this distinction is clinically significant in the sense that there are differences in how a patient with different predominance of these different subtypes respond to therapy. So why does it look different? How does it get there? Well, we know that mutations, that's not that being properly displayed, but ATM, for example, is a gene. CDOT is a cDNA change that we've detected using DNA sequencing technology, and PDOT is what we predict in terms of what has changed in terms of the gene product of ATM, for example. So ATM protein has changed, and that's predicted based on DNA change. And the NM just denote what reference transcript we've used. So that's the genotype. And we know that the genotype of non-small cell cancer with respect to what drives the cancer are quite heterogeneous. And so that involves these, for example, KRAS mutation. Fortunately, some of them will be targetable, such as the form of G12C, EGFR, and so on and so forth. And the picture can change whether this is tested at a presentation or later on. But when I look at this and say this is what I see on the slide, I cannot tell you what mutation has caused A, B, C, D, E. That's why I do the molecular testing. And there are some AI sort of tools to say, well, maybe you're more likely to have a targetable ALK mutation. Maybe you're more likely to have a targetable EGFR mutation. But this is, so there's a gap between the genotype and the phenotype. And one of the gaps that we're trying to address with the generous random we've received is looking at epigenetics. So epigenetics means that we're talking about changes that do not involve changes in the sequence. So if your tumor has a mutation, by definition, there has been a change in the DNA sequence. Whether it's a G to C or A to T, there's a change in sequence, but there are a lot of things that can happen between the DNA to the things that are downstream of DNA's messenger RNA, protein, and so forth, that can be affected and changed, and that's where epigenetics is one biologic phenomena that can involve things in form of histones, methylation, and ultimately resulting in changes in how the DNA is wound up, opened up, closed up. Because if you actually look at a cell, it's not just a bag of water with these protein molecules floating around interacting with DNA. It's actually very busy. So this is sort of a 3D structure, ultrastructure of the nucleus cross-section. So you're not looking at a bag of water, even though we all hear about how we're 70-75% water. This is sort of how busy the nucleus is, and all those proteins and DNA molecules are crammed in there and being floated around and being dynamically opened up and closed down. And we know that different chromosomes sort of are then pulled to different areas within the nucleus, forming these what's called transcription factories as well as things that we recognize just on the microscope called nucleolus, and the subsequent transcription and gene expression is actually very dynamic. And of course, we know that during the interphase, which is one phase of the cell cycle, our DNA is a little bit like spaghetti. It's very messy. It's kind of all, probably to some extent, all tangled up. But of course, as cells undergo division, these will go a certain sequence of organizations that allow the various chromosomes to be segregated to your daughter cells. But this is one of the events that do not happen normally in cancer cells. And again, when you have events in epigenetics that's aberrant, this whole sequence is going to be dysfunctional, and the result is even more and more DNA changes in form of DNA breaks and further mutation. So some of the things that we know that can happen that modulate this is something that's to do with something called histones. So histones are these complexes where DNA molecules are wound, and there's a certain number of DNA molecules that are wound around these histone octamers, and there are these tails that the histones have that undergo various what's called post-translational modifications. And so using a technique that's called immunohistochemistry that you may have heard about earlier today, what we did, first of all, was looking at types of cancers with respect to one particular histone post-translational modification. So it's supposed to be predominant on the right, histone predominant. And you can see there is that the intensity of brown stain, which is correlated with the expression level of the different histone post-translational modification, is much more intense expression on the left panel, which is heavily predominant compared to the right. So looking at these different patterns, invasive adenocarcinoma, in particular, the solid was where you had the lowest form of this one particular histone post-translational modification. So this was just based on a smaller series of cases. And so what we did was to form a cohort of lung cancer patients that were seen at St. Michael's and St. Joseph's Hospital, which have since come together as Unity Health Toronto. And we did retrospective chart reviews and identified about 400 patients and formed what's called a tissue microarray. So what that allows us to do is single slide. Example shown on the right, you can look at a single set of markers using a single slide, allowing for multiplexing of a number of patients and a number of different cancer types, cancer samples on one shot. And so the idea is that instead of using immunohistochemistry, which generally allows you to just maybe look at one or a couple of markers, we can do what's called multiplexing of fluorescence. That allows us to use different colors and layer different markers to look at various histone modifications all at the same time. And so the idea is that by better understanding this epigenetic phenomena, one of the things that we know is a possibility is that a lot of these are actually well in use for mostly for hematologic malignancies. So there's things like HDAC inhibitors and histone methyltransferase inhibitors and so on and so forth are already in use, but not so much in lung cancer. So the idea is that by better understanding the things that are aberrant in lung cancer with respect to these epigenetics, perhaps we can identify new targets, as well as understanding how things come about in the first place and how that interfaces with genotype, genetics, all the way to phenotype, which ultimately is cancer. So these are some of the preliminary results looking at just one set of 10 markers on a very small area within a tissue microarray. And what you can see here is that see is these various different cell markers, as well as for particular histone modifications. The idea is that we can have a cell-specific expression pattern for a single cancer core. Then, of course, by doing it in a tissue microarray, then we're able to do this in hundreds of patients all at the same time. So this is very much in this active phase, and hopefully the idea is at the end of the day that by looking at these data in a systematic manner, they can potentially uncover diagnostic, prognostic, and predictive markers, as well as potential therapy targets. So lots to do, and thank you again for the generous support, and I'll take questions.
Thank you so much. Questions over to me. So, it's my pleasure to introduce our next speaker, Winky Al. Winky Al is the coordinator of medical affairs here at Lung Cancer Canada, and she joined our team in July of 2021. She holds a BSc in Health Sciences from the University of Waterloo and is passionate about health promotion, advocacy, and working to remove barriers and inequities in healthcare accessibility. She lives in Markham and enjoys drawing and painting in her free time. Welcome, Winky.
Thank you, Michelle. Nice to see everyone here. Okay, so I know we're running a little bit late on schedule, so I'll just try to breeze through this. So today I'll just be talking about, demystifying the drug approval process and public funding pathway here in Canada. It's a little bit complex, so I do have, if it works, a short video to kind of introduce the topic. Oh, there we go.
Canadians wait 2 years for access to new medicines through our public drug plans. That's a full year longer than patients in most other peer countries. As a result, Canada ranks last in the G7 and 19th out of 20 peer OECD countries in the time it takes for patients to get access to new medicines and treatments. These delays in patient access are caused by Canada's complex drug access process. Let's explain how the process works. A new drug is submitted to Health Canada. They are responsible for evaluating the drug's safety, efficacy, and manufacturing quality. The PMPRB then reviews the price of the drug and continues to monitor it throughout the patent period to make sure prices aren't excessive. Once the drug is approved, Canada is responsible for conducting health technology assessments to make funding recommendations for Canada's public drug plans. This is where the waiting really begins. There's a 3 to 4 month delay before the drug moves on to the next stage of the process. The PCPA will then conduct pricing negotiations on behalf of provincial, territorial, and federal drug plans. After negotiation has wrapped up, provinces and territories eventually list the drug, with times varying significantly across Canada. 2 years can feel like a lifetime for a patient and their loved ones while waiting for access to a life-saving medicine or treatment. Canadians need faster access. Visit innovativemedicines.ca/pathway to learn more.
I won't go into too much detail because actually the video that I just played from Innovative Medicine Canada, I just want to give them a quick shout out. They have a really great resources on the drug approval process, funding, all about that process in Canada, so give them a check if you want. I'll be quickly going over how the process works in detail. So quickly, this is just an overview of the Canadian drug approval process. Like the video just mentioned, it's quite complex and it goes through a lot of different steps, from Health Canada approving the drug to be marketed in Canada, to undergoing the health technology assessment by CADIF and INES. CADIF basically takes care of it in all the provinces in Canada, aside from the territories and aside from Quebec, and the INESSS takes care of this process in conjunction with CADIS, but only for the province of Quebec. After that, it goes through the pricing negotiations confidentially via the PCPA, the Pan-Canadian Pharmaceutical Alliance, and also just, I guess, on the side, the PMPRB, the Patented Medicines Pricing Review Board, oversees this entire process up until the final step, where it goes to the provinces and territories to make the ultimate final funding decision. They oversight the entire process to make sure, like the video said, the ceiling prices or the maximum prices of this new drug being publicly funded in Canada is not crazy excessive, and there's a maximum ceiling price. So they regulate that and monitor it regularly. So this is just a quick overview. I'll go through each of these in detail in a bit. But I just want to make a quick shout out to the side where it says private insurance and self-pay. So, like the video said, this entire process, to be quite honest, is very long. It takes about 2 years for it to go from first Health Canada approval up into the hands of patients and having it publicly funded in Canada. That's quite a very long time for patients to wait and have access to these new life-saving drugs. So the main reason why Canada ranks pretty low on in comparison to other countries in the OECD, so for example, US, the UK, the reason why it takes so long is because of this, 1, 2, 3, 4, 5 step process and the delays that happen in between each step. So for example, the United States, which is, I guess, the main comparison to Canada's process, and you guys are probably pretty aware of it, they have a private healthcare system, right? So their equivalent of Health Canada approval of having the drug being available to sell and market in the United States is done by the FDA, and private insurance companies in the United States only require FDA approval before they're able to cover it in their insurance policies, right? Or having patients pay out of pocket. FDA approval is the only step they need, or the only approval they need to move forward. So they are able to skip all the 4 steps beneath that. And similar situation in the United Kingdom as well, right? And many other countries in Europe and Australia, New Zealand. In the UK specifically, the NHS, they're the only ones that need to give approval before the drug is publicly covered in the United Kingdom, right? So they can also skip basically most of these steps, and it takes significantly less time in the United States and the UK than it does in Canada. So that's something that we really need to improve on as a healthcare system. Okay, so just in detail, the first step is Health Canada approval and pricing review. So basically, once the manufacturer intends to sell this new drug in Canada and have it be available in the Canadian market, they have to submit to Health Canada, right? So Health Canada basically assesses this new drug wants to be in Canada. They assess the baseline safety, this efficacy and quality of the new drug, so that it's safe, it works, it's of good quality based on clinical trial data. And most of the time, this basically is submitted by phase 2 clinical trial data or phase 3 clinical trial data as of recently. So making sure it's equal or as more effective or better than what's already available in Canada in terms of other treatments. In conjunction with that, the Patented Medicine Pricing Review Board, the PMPRB, like I said, regulates the maximum prices of these patented medicines sold in Canada, so making sure they're not a crazy excessive amount. And then after that, once Health Canada gives their approval, and unfortunately this step only takes almost a year, 300 days. So that's already quite a long time to even say yes or no to having this drug available in Canada. And if they do approve it, they will issue a notice of compliance, sometimes with conditions, which is for the cases of oncology drugs, for example, for lung cancer. They usually approve it with conditions to make sure that there's further data being reviewed in the meantime while the process keeps going on with the other steps. So step 2 is a public reimbursement analysis, or basically deciding whether or not this drug should be publicly funded. So once Health Canada gives their approval, yes, we can have this drug available in Canada. It's not yet funded by the Canadian healthcare system, right? It has to go through this step, which is kind of governed by CADIT, the Canadian Agency for Drugs and Technologies of Health, and similarly INES in Quebec. They take care of this step and deciding whether or not this drug should be publicly funded. So this process is called Health Technology Assessment, or HTA, and CADIS basically assesses the clinical data from the clinical trials again, quality of life of patients on this treatment through the clinical trial examples, or some manufacturers or pharmaceutical companies might have special access programs, and getting data from that, the cost versus quality of the drug, and also comparing it to treatments already available on the market. So in the context of lung cancer, for example, a new targeted therapy drug being marketed in Canada and undergoing these steps, they'll probably compare it to, is it better than chemotherapy, or is it better than radiation or immunotherapy? So those are the kind of typical treatments that we see in the lung cancer space, so comparing it to what's already available in Canada. This is also the only step in this entire 1, 2, 3, 4, 5 step process where external feedback is accepted, I will say. So regularly, patient and physician groups, including Lung Cancer Canada, will submit to CADIS and to INES as well to kind of give their feedback on this whole process, making sure the patient values and the clinician values are heard and also respected during this entire process. And this step, again, takes quite a long time, 6 to 8 months is usually the timeline that it takes CADIS to review and make a decision on whether or not the drug should be publicly funded. I'm not sure how familiar you guys are with this process, but sometimes if you've been following this sort of public funding procedures in Canada, sometimes drugs are not approved, and that's very unfortunate because that means it is still approved by Health Canada, so it got through the first step, but the second step of it having public funding in Canada and just across the nation is not granted by CADIS, right? So that's very unfortunate, and it really limits the access that patients are able to have with this new drug that could potentially save their lives, right? And sometimes with the lung cancer field being very new and new targeted therapy drugs being undergoing this process, it's quite hard to access. So the main reason for why CADIS might not approve these new drugs, or at least that I have seen in my cases in the last couple of years, is because of the lack of traditional data. So some pharmaceutical companies, when they conduct clinical trials, they do phase 2 versus phase 3, or they submit, I don't want to say premature data to CADIS, but they haven't gone through the phase 3 data or phase 3 clinical trial, which basically means that they haven't compared this drug to what's already currently available in Canada. So comparing this new targeted therapy to chemotherapy, for example, or comparing is it better than radiation or better than immunotherapy or other similar drugs. So that's pretty much the main reason why CADIS, in my opinion, won't recommend these drugs. And also the second one is cost. So very unfortunate process. So step 3, let's say this new targeted therapy has got the okay from Health Canada, it's ready to be approved, got the okay from CADIS to be publicly funded in the nation. It has to go through pricing negotiations. So this step takes quite a bit. It's a bit delayed between the CADIS step and starting the pricing negotiations, so about 4 months in some cases. So that also adds fuel to the fire of why it's so delayed and takes so long for patients to have access, right? So if it does go through CADIS and is recommended positively to be publicly funded, the PCPA, or the Pan-Canadian Pharmaceutical Alliance, they basically are a nonprofit organization that kind of covers all of the provinces and territories and conducts pricing negotiations for this drug on behalf of all the public payers in Canada. So each Canadian province has their own healthcare system and their own drug formulary of funding of which drugs they want to fund. PCPA covers all of that and negotiates on behalf of all the provinces to make sure there's like one kind of standardized answer, yes or no. So this process is quite confidential. It's between the manufacturer themselves and the PCPA. No external input is allowed during this stage. And it takes quite a bit, about, I want to say another few months, 4 to 5 months. So again, quite lengthy and successful negotiations. If they get the okay and they agree on a price, they'll send a letter of intent between the manufacturer and all the public. all the public plans across Canada. So that's step 3. And then the final, and I guess unfortunately the longest step or the most difficult step to get over is provincial review and decision. So once a new drug has gone through all of these steps, got the okay from Health Canada, got the okay from CADIV, and agreed on the price with PCPA, at the end of the day, it's up to the individual provinces to decide whether or not to fund this drug. So it's based on their budgets, and then it's based on what the PCPA has negotiated on their behalf, and taking all of that information that they've received from this whole process, and then the Minister of Health in each province making the final decision, yes or no, what price to put it at, what criteria, what specific terms and conditions they'll have for patients to access it or require for patients to access it. So there's quite a bit of limitations and differences between each province. And unfortunately, this step I'll show on the next slide an example. It has the most significant variability in how long it takes for each province to fund one drug versus another province. Some provinces might choose not to fund it at all, while other provinces choose yes. Some of them might undergo another HT review to inform their decisions and make sure they have the okay. And in Ontario, specifically, these drugs that do go through this process will be covered under the Trillium Drug Benefit in Cancer Care Ontario. So I'll just show on the next slide, but quickly, the average trend that I've seen, Atlantic provinces in Canada are typically the slowest to approve new drugs and add to their formularies, which is very unfortunate. But I guess for us folks living in Ontario, Quebec, and BC are typically the quickest to add to their formularies, and for the most part approve new drugs first. So I'll just give you a quick example. So this is a chart that I took from our Faces of Lung Cancer report from last year, 2023. So just a quick shout out if you're interested in seeing more of this. It's available on our website, lungcancercanada.ca. But this is a chart basically displaying the number of days it takes from the date of FDA approval, so in the US when it gets approval there, to the date of provincial coverage here in Canada. So I'm not sure if you can quite read it. But for example, there's quite a bit of variability in this chart. So for example, I'll just take one lurbinectedin, the drug fourth down from the top row. It got approved by the FDA in June of 2020. However, it's not funded in any of the provinces yet in Canada. So BC, Ontario, Alberta, anything like that, not funded at all. And that's because it didn't go through the CADIV process of step 2, so it didn't get the okay to be publicly funded in Canada. However, for example, osimertinib first line, it got approved by the FDA in the United States in April of 2018. And we can see here, I'm not sure if you can quite see, that's this one. So let's say BC, it took about 623 days. Ontario took 632 days as well. Quebec was the first one to approve it in 609 days after this April 2018 date, so a little bit less than 2 years. Quebec approved it, so did BC, Alberta, most of the other provinces. However, at the very end here, you can see the PEI is the second last row. It took them 1,398 days. So if my math is correct, that's a little bit 3.5 to 4 years after it first got approved in the United States. So that's quite a significant difference, for example, from Ontario, which took a little bit under 2 years. PEI took almost 4 years to approve it. And then we can see the same thing as well with pamrevlizumab. It got approved in the US October 2018. All the provinces took average 500 to 600 days, so under 2 years to add it to their formularies and cover it publicly. However, PEI, again, they took 1,159 days, so if my math is correct, about 3 years, I want to say, to approve it, which is quite concerning. So that's a general trend, and then even here, for example, sulbrecatinib, which is a drug for red-positive fusion lung cancer, it got approved by the FDA in May 2020. All the provinces, on average, took 1,200 days, approximately, and it's still not funded in Newfoundland or PEI. So in each of the provinces, and it's, like most of you have probably seen, even online, it's a concerning process for sure. We're working very hard to advocate for this to be more equal across the nation, but it's a difficult process for sure. So just a quick update on how things might change. So the Canada Drug Agency was actually announced in December 2023, and this will be built from the existing CADIV in partnership with the provinces and territories. And this new Canada Drug Agency, the CDA they call it, is intended to streamline HTA processes, so deciding whether or not it should be publicly funded, these new drugs, also streamlining post-market evaluations and the safety of prescription medicines and health technologies in Canada. So basically what CADIV does right now will be streamlined into a more, centralized agency. And Lung Cancer Canada will be closely monitoring this. There hasn't been too much information since the initial announcement, but we'll be following this. So quickly, the role that we play at Lung Cancer Canada in all of this process. So a key cornerstone of what we do as an organization is advocacy, and specifically advocacy for access to new treatments and public funding of drugs in Canada. So just, this exact talk that I'm talking about today. We are committed to ensuring that the patient and physician voices are heard and included in this decision-making process as best as we can. Like I said, in step 2, when CADIV decides whether or not to publicly fund new drugs in Canada, they're the only step that really allows external feedback to be submitted to them and have a say in the decision-making process. So Lung Cancer Canada regularly submits our input both on the patient group voice, but also on the clinician voice with our medical advisory committee to submit our feedback and our inputs and opinions on this whole process and making sure that patients have access. And we're doing our due diligence in making sure that this process is as streamlined and as fair and patient-centric as we can. So making sure that ultimately we want more drugs to be funded in Canada, right? So patients have more access. So that's a key cornerstone that we do. We're also quite active in our own and through coalitions as well. So some groups that we're in partnership with. So for example, the Lung Health Foundation, Canadian Cancer Survivors Network, some of the coalitions we work together on finding efficiencies in the process to help get drugs to patients sooner. So that was quite long, and I hope it was quite clear. It's quite a complex process, but I'm happy to take questions.